Now the next speaker is from Basel. Marios, are you there?
I'm here. Hello, everybody. Can you hear me?
Hello.
Yes, we can hear you, Marios.
Thank you for the invitation. I'm really sorry that I cannot be there. I would love to be there in cool Belgrade. It's really hot here in Switzerland, 30 degrees today. And I have to take over and on call for a colleague, so unfortunately I cannot be there. So my talk is about next frontier in stroke. These are my disclosures. I don't want to show you, what we know. I'm concerned a lot of times about what we don't know. So I'm going to show you what we are trying to do to actually get some ideas of, what we should do. So distal occlusions is a frontier in stroke, and we have to decide between secondary and primary distal occlusions. Let me show you a typical case. This is an M1 occlusion with a nice mismatch. We went on and treated this patient, as you can see here, with stent retriever and aspiration catheter. One pass, you're opening the vessel, and then you see this, right? M1 is open, you're happy about the result, but of course you already saw, there is, Vlado already saw that, an ACA occlusion there, right? And now the question is, what would you do? I'm pretty sure like 10 years ago, maybe some people would have left it and say, well, TPA is on board, the vessel will open at some point. But today we're not doing that. We're taking smaller materials. This is a 3 millimeter Trevo, and going with smaller aspiration catheters and opening the ACA as well, right? So this is something that we do. You can see here the nice TQ3 result after the 2 maneuvers. And so for the secondary distal occlusion, we actually didn't leave it like this. We went on and treated with another stent retriever. The question is, do we always have to use stent retrievers? If we have a residual M4 occlusions, M4 occlusion, would we go all the way to the M4 with a Tiger, for example? Or can we also give some medicaments intraarterially? And that's why I will talk to you about the Techno trial, which we started together with Bern. Johannes Keesmacher is actually the PI. I'm a co-PI or collaborator in the trial. Actually, it's about a randomized trial on giving intraarterial tenecteplase or leaving the patient without another reperfusion or intraarterial recanalization maneuver. As you can see here, it's the primary endpoint is reperfusion. So you want to see that you are opening the vessel after giving a bolus of TNK with a microcatheter in front of the occluded vessel. It's a really simple design. TNK is just a bolus, so we give 3 millimeters through the microcatheter, and then we are waiting for 20 minutes and doing a series. Again, it's a randomized trial, so after doing your maneuvers in thrombectomy, you can go on and give TNK. Okay, so this is one thing about secondary distal vessel occlusions. What about primary distal vessel occlusions? Because we see that more and more nowadays. In Basel, we started doing more and more perfusion also for low NIHSS patients. So actually, we do now perfusion for every patient. And we find around 30 to 40% of our patients have a medium or distal vessel occlusion. And again, before you go on and treat every one of those patients, you have to keep in mind that we only have evidence from randomized controlled trials about dominant M2 occlusions. So actually M1-like M2s. Regarding those smaller M2s, M3 occlusion, ACA, PCA, we don't really have data from randomized controlled trials. So this is why we try to define what for our trial would be a MIVO, and you can see the definition here. So we are not targeting the dominant M2s, but we are targeting the non-dominant air and the co-dominant M2s, but also the ACA and PCA vessels. And if you're asking, okay, what's a dominant? Are we talking about the left side? No, a co-dominant M2 is supplying nearly half of the MCA territory. As you can see here, we have a Tmax of 90, and we know that the MCA territory is around 200 cc's. So this is around the half of the MCA territory. What about the non-dominant? This is clearly a non-dominant M2 occlusion. You only see 40 cc's, and this is a perfect candidate for our distal trial. And the point how we calculated for the trial, you can see here, is that those patients really have good outcomes. We have 70% of MRS 0 to 2 without thrombectomy. So again, if you're going to do it, you have to be sure that you're not producing complications, that you don't have bleedings in every other patient that actually worsen the outcomes of those patients. And again, I told you before, now that we do more and more perfusion, we actually find more and more of these medium to distal vessel occlusions. So again, imaging modality, I will go fast through that. We chose the CT, CTA, and CT perfusion protocol. Why? Because there are studies showing that, you know, if you don't do CT perfusion, if you're going more distally, you may miss a vessel occlusion on CTA. So actually, CT perfusion helps a lot. You see the deficit, you go back to your CTA, you check this territory, and then you maybe find a M3 or M4 occlusion. This is another trial showing that the sensitivity, if you're using perfusion, is much better for those distal occlusions. And again, this is something we do for every patient now in Basel. Let me show you a nice example. Young patient, late window, comes in with an NHS of 9. CT shows nothing, no bleeding. CTA, we weren't really sure about the clot there. We did perfusion, see a deficit. Actually, you can see here, not really a big mismatch, right? But keep in mind, those are algorithms that are made for LVOs. So again, I wouldn't trust 100% this core image for DVOs. Here there are the single cards if you need them. You can see some mismatch there between CBV and CBF. Also some mismatch on the superior post-central region. And so we went on and treated this patient. And this is the result after 1 day, where you can see now the mismatch between the initial perfusion deficit and the DWI. So actually we were able to save brain in this case, and especially again, supporting my claim about the core imaging here, showing the difference between the rapid core and the DWI. So actually, I think even in the late window, we might have some evidence in the next years that we should go on and treat those patients. What about the tools? Do we have the tools at the moment? Well, yes and no. So right now we're going more and more to those M3 occlusions, targeting these M3 occlusions, as you can see here. If you allow me to measure this vessel, you can see we have 0.8 millimeters of vessel diameter. So there are people saying, well, you take a Sophia 5, a Catalyst 6, and you go on and aspirate there. Well, if you ask me, I don't think that's the best of ideas, right? This is an already dilated vessel from the occlusion. If you take a Sophia 5, you will over-dilate, and maybe you have a complication there. Even with a newer Red 43, you will see we have a much higher diameter. So I think we need, as also Mark said, better, newer tools. I'm proposing to Penumbra that we need something like a Red 35. You mean like a newer, better 3MAX, for example. But again, in this case, I went on and aspirated first, didn't get the clot out, and then I used the stent retriever, as you will see here, together with the small aspiration catheter, together with a big aspiration catheter in the M1. So actually 4 devices with a guide catheter also. This is what we call now the Quattro technique. The paper has been accepted actually, and it's going to be online in a couple of weeks. So this is how we now try and treat those vessels. You can see the result here. You go on and remove the clot, and then you have a nice reperfusion result. The TK3 for this territory of the vessel. If you want more details, I know it's not the time now to have more details about that. We have some nice pictures and some nice details also on YouTube. So you can go and check our YouTube channel. If you type One Stop in Stroke in YouTube, you can actually find also a talk about distal occlusions there. It's 1 hour of just talking technique. And this is the QR code if you want to go and find directly our channel. So again, the question is, should we treat those occlusions? We don't have evidence, right? And of course, we have proven our Greek colleague wrong about treating a severe apoplexy. We know now that you can treat this. You know that you should go on and open the vessel, but we don't have yet the evidence about the mild ones. As he says, it's difficult to cure one. Well, we will see. That's why we're doing the distal trial, which is a randomized trial about distal occlusions. And the design is pretty pragmatic. So the patient comes in the hospital, you do your imaging, you give your TPA, you do your standard treatment, and then you randomize the patient into going to the angio or no angio. And the primary outcome is going to be MRS after 90 days. You can see here the countries that we are at the moment. So actually we started in Switzerland, and then we were able to expand and having a European trial at the moment. We are aiming for 526 patients. At the moment, we have 42 activated sites. So our team does a great job of actually being a multi-country CRO for all those sites. And one thing that's new, and I'm really happy and glad that it happened, is that we are now talking, and actually we're preparing the contracts with the Mr. Clean group. So the Dutch are going to be also on board, and this will help maybe finish the trial also in the next year. At the moment, this is the graph from the end of April. Now we have the start of June, and we are at 198. So I hope in a couple of days we will have 200 patients, and then we need 300 more to finish the trial. So if I can have a take-home message, perfusion thresholds are important. We use perfusion a lot in order to find MIVOs. We do thrombectomy, and we try to randomize patients in the trial. And regarding the technique, we use a combined approach because we think that proves that gives us better outcomes for the patients and less bleedings. Next frontier is ICAT-related vessel occlusions. Last year, I presented the guideline on the ESOC about ICAT. And one of the questions we had there was about LVOs and acute vessel occlusions and what we can do if we cannot open the vessel with mechanical thrombectomy. And as you can see, the quality of evidence is really, really low. So we don't know if we should do rescue stenting. We do this also in Basel all the time, but actually we don't have randomized data to show us if we should do it. And I was really surprised in the guideline when I asked around and I said, well, you do 1, 2, 3 passes, the vessel doesn't open. What do? Don't you go on and stent? And there were a lot of neurologists that were very, very reluctant to go on and stent, actually. As you can see here, this is my proposal as a consensus statement, where we say, well, if you don't open the vessel, you should consider stenting and doing PTA rescue, right? And you can see that still about 1/3 of the group disagreed with its statement. So again, this is really, really important. I think we need also a trial in this case. And this is a nice example from our clinic. Young patient, low NHSS for his M1 occlusion, no atrial fibrillation, has some risk factors for ICAD. CT was showing some older borderline infraction. On the CTA, you can see a truncal type of occlusion in the M1, not on the bifurcation, but on the proximal part. Perfusion was pretty good for this M1 occlusion, so very, very good collaterals on this case. And you can also see this here, no core there, despite the M1 occlusion. So we started thinking about, signs of ICAT-related vessel occlusion. Truncal type of occlusion is one. Low NHSS for this M1 occlusion with very good collaterals is another one. No core on perfusion, no atrial fibrillation, and this so-called tapering sign. This was also seen in our case, kind of. So again, for me, after seeing that, after doing the angiogram, I was pretty sure this is ICAT related. So we did one pass, and this is the result after the first pass. So you can actually see, I don't think this is a dissection, right? It could be a residual clot, but if you take all the other signs, I was pretty sure this is ICAT related. So what I did is I went right away after the one pass and stented or decided to stent. Usually what we do is we wait for 5 minutes, do another angiogram, and then when we do the second angiogram and you see, oh, okay, this occludes now, then we go on and stent, but the decision was made before, so we had prepared everything. And as you can see here, we load them with aspirin and agrostat. We go on and do the PTA with our NeuroSpeed. And of course, having new devices with coating would be great. That was a case from last year, so I didn't have it. I used Acredo, as you can see here, with a really nice result in the angio. But again, if you have now coated device, now we have this in Basel, and I also have done a case where I just gave aspirin intravenously and went on and used the Pegasus HPC for an acute rescue stenting. So again, really good result in this case. The patient was discharged with an HS of 0. And what we think is that we need also a randomized trial. In this case, we have started and we have applied for a grant in the Swiss government for the Icarus trial. And the idea is to do maximum 2 pulses of thrombectomy. If you think it's ICAD related, then you can go on and randomize and you do rescue stenting or whatever else you would do. Give aspirin, do some more passes, or leave the vessel like this. This is the group that conferred a couple of months ago. A lot of people that you know, Mark is also on board. And we had a great discussion about, which patients we should agree in the interventional group, if we just stick to basilar and one, or if we have to do also distal vessels. We have applied for the grant. We are waiting for the response. If you're one of the reviewers of the grant, please be kind with us. I think it's an important trial. And we hope that we can start the trial in Q4 of 23. But again, I think this is going to need a lot of sites because I don't think we have as much ICAD-related LVOs or vessel occlusions as we have distal occlusions. So altogether, that brings me to the end of my presentation. Me and my whole team, thank you for the attention and for the invitation to present some of our thoughts here. I would love to welcome you to Basel next year for the ESOC, which is happening here. So if you don't have this in your calendar, please come to Basel and have a great Congress with us. And thank you very much for the attention.
Thank you, Marius. Do you hear me?
Yes, I can hear you. Can you still see my slides? So, let me stop sharing.
Tell me about your antiplatelet regime after the acute stent placement.
So again, usually what we did was give intravenous aspirin, 300 to 500 milligrams, and also start with a bolus of agrostat and then continue with the perfuser. In the last couple of cases, which I have now, the Pegasus HPC, I just gave the aspirin. I waited 1 day, and then after the 1 day, if I didn't see a big infarction, I continued also with Plavix. But again, this is, I think, a nice improvement. And this, at least in the couple of cases that I've done until now, the vessels have stayed open.
And Vlado here, how do you size the Pegasus HPC when you have a M1 ICAD? What is your, depending on the diameter of the proximal part of the M1, or how do you size?
Yeah, we try to undersize. So usually we try to take a 0.5 millimeter or smaller than the proximal part or the part that's occluded. But of course, regarding the sizing, sometimes you don't have all the sizes. So actually the stent is oversized, so you can then undersize for your PTA.
And one question for the first part of the lecture. What is your rate of subarachnoidal hemorrhage when you go distal? How do you?
So we started with I would say a high rate like 4 or 5 years ago. I think now with having better techniques and also smaller devices, we have dropped this down to around 20%. There is a nice big meta-analysis showing that by doing combined, you have around 15 to 18% of subarachnoid hemorrhage, but you have much less symptomatic hemorrhage with combined approach. So again, in this meta-analysis, there is a symptomatic intracranial hemorrhage rate of around 2% for a combined approach.
Thank you.
But anyways, you don't care if it's TPA on board or not when you do distal, yeah?
No, that's not a problem in my eyes. For the trial, that's of course okay, because we want to have the standard of care and not disrupt this for the trial. And we know that it will dilute a little bit the mechanical results, right? But in the end, what we are comparing here is not just the angio versus just giving medication. We are comparing the combination of TPA or lytics and going to the angio versus not going to the angio. So I think it's, as we know, or we think now about LVOs, we are also doing the combination and having this as a gold standard, right?
Thank you very much, Marius, for your effort, and nice to have you here, if not live like this, and hope next time you will be.
I hope next time I'm there. And again, thank you so much for the invitation, and have a great Congress.
Thank you. Bye.
Thank you. Bye-bye.
Bye-bye.